So I'll start off with a case. A 38-year-old male, history of fall from a bike, had got other concomitant injuries also, but suffered a greater tuberosity fracture. This is the X-ray. We'll come back to the X-ray later on. So the objective of this talk is going to be different modalities of treatment of greater tuberosity fractures and different methods of reduction. So greater tuberosity fractures account for 20% of all proximal humerus fractures. They are associated with dislocations usually. It's not every time that you'll get a dislocation, but the violent force do cause dislocation. It can be treated non-operatively. This talk is not about saying that you need to operate every single GT fracture. It can be treated non-operatively. We'll come to the reasons for why to operate on the patient. They are associated with glenoid fractures, labral injuries, plexus injuries. So we have to look for all of the concomitant injuries. A simple AP X-ray also will give us an idea about glenoid fractures. We can do further evaluation in the form of CT scans, MRIs, neurological examination. But I'm not going to go into details of this because this is a master class and not a basic course. The classifications, we all know about the AO classification. It's an extra-articular two-part GT fracture with less than 5 millimeter displacement or more than 5 millimeter displacement. There are three subtypes: undisplaced, 5 millimeter displacement, and fracture dislocations. The famous Neeraj classification, where there's 1 centimeter displacement, if it's seen, then we should operate. There's a morphological classification which is more up to date according to me. It was propagated by Murphy et al. So they divided GT fractures into 3 types. Type 1 is an avulsion type of injury. Type 2 is a segment of the GT that is split. Now this type 2 can be divided into multiple types again. But that has not been said in the paper. The paper only suggests of a split type of injury, and type 3 is a depressed type of fracture. Now depressed type of fracture is like a Hill-Sachs injury that happens in dislocations. It's just a depression that is there. It can be conserved. So the mechanism of injury based on the morphological classification. Type 1 is a avulsion type of injury. It's basically like a rotator cuff tear only, but it's taking a part of the bony fragment with it. It's a massive injury which the rotator cuff contracts and the shoulder dislocates, and therefore the avulsion happens. Type 2 is more of an impact type of injury in which the hand is hyper abducted and there's a direct impact which happens of the greater tuberosity over the acromion, and that causes a depressed type of fracture. And type 3, which is again the difficult type, I would say, because it's a shearing type of injury, a massive type of injury. It can be coronal splits can be there. There can be different, there can be more than 2 parts. There can be tear of the rotator cuff. There can be an injury of the glenoid also. So type 3, type 2 is the one that has got more variations present. So once we see that type of fracture pattern, we should be aware that we have to look out for other injuries also and plan the surgery accordingly. So who do we operate? Patient's demands and patient's expectations. That's the first thing, because many of these injuries happen in older individuals who are anyway not able to do a lot of the day-to-day activities which they wanted to do. They have overhead abduction up to around 70 degrees, 80 degrees, and they're happy with that. So why to operate those people? Younger patients, good bone stock, everything is good. Then we need to find out, okay, will this patient do well or not do well with the surgery? So there's a paper again by I'm sorry, I cannot say the name very well, Neiffeler et al. So they came up with this impingement index. It's really simple to do. If you read the paper, they've explained every single step of how to take a simple AP X-ray. They do it in 30 degrees external rotation. Now there are 3 lines that are shown out there. It's the RH from the center of the head to the articular surface of the humerus, RT, which is from the same center to the GT, to the edge of the GT, and RA, which is from the center of the head to the acromion. Now, it's formula based. I know when you read the formula for the first time, it's like it doesn't make sense so much, but it's very simple. It's the distance from the greater tuberosity minus the humeral head, that distance divided by the distance from the acromion to the humeral head. When that is done, the impingement index is found. And if you go to see if a person is any height, we always remember the 5 millimeters or 5 to 7 millimeters is the distance between the humeral head and the GT. That's the way that we are taught. So they're using the same concept, and if the impingement index is greater to or equal to 0.7, then the patient will be benefited by doing a surgery. I know it's too much of information, but it's something to go back home and think about. That this is something that we can understand, that which patient will do better with the surgery or without the surgery. The treatment options. There's arthroscopic, percutaneous, open. In all these options also, then you have another set of options, which is sutures, suture anchors, screws, plates, hybrid. So what do we do? So arthroscopic, let's start with the first one. For avulsion type of injuries, it's basically like doing a rotator cuff repair. However, I'll just go through one of the papers. This is the arthroscopy technique paper by Godia, in which he's done a arthroscopic repair for the GT fractures. This is his pre-op X-ray. He went in arthroscopically, debrided the base, reduced the fracture fragment, which can be seen on the CM picture, did a double row fixation, and this is his post-op X-ray. There have been papers suggesting that arthroscopy versus open techniques comparative, there is no significant difference between the results. However, if you have a concomitant Bankard injury, it would be beneficial to do an arthroscopic surgery for the same. If you have only a rotator cuff, a GT fracture, then doing a percutaneous or a mini open will suffice, because the operative time will be reduced. The paper that I'm quoting, the operative time was compared between open and arthroscopic. There was 30 minutes for open techniques, 95 minutes for arthroscopic technique for the same surgeon. So it all depends. However, arthroscopy does have its benefits, but we have to understand that certain times in this day and age, we have to see the benefit to the benefit ratio for the patient also. Now coming to the percutaneous technique. In this technique, we have a large fragment. They have to have a good bone stock. If it's paper thin bone, or there's just a sliver of bone, doing a percutaneous technique, you will end up shattering the bone. So therefore, it has to be a well selected case that you do it in. There are percutaneous methods in which you reduce the fracture fragment. You can put a simple skin hook, you can put a bone hook, you can put any periosteum elevator to elevate the fragment and then reduce it, temporarily fix it percutaneously, and then put in your CC screws. Open method. Again, if there is a comminuted fracture, if there is a bone stock which is doubtful and it's got a distal extension, approaches, we've just heard a very good lecture on deltopectoral and lateral approaches. What are the different modalities of treatment? So GT, you can do a lot of modalities of treatment. You can put in 2 CC screws, you can put a plate, you can put in a TBW wire, you can put in a suture anchor with a screw fixation. But in all of them, there is one common thread. Once you do open, use the rotator cuff. Use the cuff because that will aid in your reduction, that will aid in tensioning your rotator cuff, and it will also, if it's a lot of comminution is present, then you will not need to put a screw or any other method or any other modality of treatment for the fixation. Again, you clear out the fracture fragment. Once you have reached the GT, in whichever method you want to, you can do deltopectoral, lateral. You clear up the fracture fragments, you reduce it temporarily, and then after that, according to your pre-op plan, we go ahead with the next step. There's trans-osseous suturing methods also possible, in which you pass the suture through the base, through the junction of the articular surface and the fracture fragment, and pass it distally and tie knots, and that will also help in aiding in reducing and keeping your fixation sturdy. There is another method which is given by, again, Dr. Dimakopoulos. Sorry for again, I'm very bad with names, but it's a very interesting paper. It's a very old paper. It was a JBJS article in which he uses only suturing techniques for not only 2-part. I'm just showing 2-part right now. He does it for 3-part, 4-part. It's slightly complicated, but it is something that we can go home and read about. Using a plate. Again, GT fixations with plate, the basic purpose of the plate is so that you can pass your thread through the rotator cuff and then pass it through the plate and use it, parachute the plate onto the bone and then fix your proximal humerus along with your GT. So coming back to the first case, 38-year-old male having an avulsion type of fracture. Now that we know our classification, what would we going to go about doing? There is arthroscopic that can be done. There can be. Now, it does look like there's a concomitant glenoid fracture also in this patient. However, their CT scans were done and it wasn't there. It was only a sliver of bone that was there. Arthroscopic, as it takes longer duration, even though it's simpler to do, I went about doing just a trans-osseous suturing technique. That's the sutures that were there. I use a lateral approach for fixation, and that was the post-op X-ray. Coming to another case, 39-year-old female having a fall down the stairs. This is a type 2 fracture, shearing force. Went about doing a hybrid fixation with screws along with the trans-osseous sutures, because MRIs were done and there was a partial tear of the rotator cuff also. So that was also healed up. Again, lateral mini open approach. So there are different modalities of treatment for GT fixation. Keeping a backup available is always very important. You can use suture anchors. They are expensive, but they are very good method of fixation. Using the rotator cuff as a fixation aid and a reduction tool is very important. And let's not also forget that non-operative can work in a lot of patients. We have to remember the impingement index. Thank you.